Welcome back. So we're going to go over this figure really quick. So this is figure 26.10 in your textbook. And what it's showing is how we maintain water balance. So if we have insufficient water in the body, then that's going to lead to a decrease in blood volume, which decreases our blood pressure. It also increases our plasma osmolarity. So what is osmolarity? Right over here you can see it's the ratio of solutes in a solution to the water in a solution. And this helps to determine our hydration level. So if we have a high blood osmolarity, that means that we are dehydrated. So this is going to stimulate our mouth to feel dry, and osmoreceptors in the hypothalamus are going to be stimulated. The stimulation of these osmoreceptors in the hypothalamus, our dry mouth, and the decrease in blood pressure, which will cause us to produce angiotensin II, are all going to stimulate the thirst center of the hypothalamus. Thirst center of the hypothalamus is going to stimulate us to want to drink because we are thirsty. It's going to increase water intake, which is going to decrease our plasma osmolarity back to where it's supposed to be. So most of the water loss that we have occurs via the urinary system. So almost all of our water that we lose is via urination. But not all of it. Like I said, we can lose anywhere between half a liter, that's our obligatory water loss, up to 2.5 liters. And there's going to be different hormones, specifically ADH is going to be one of those hormones, that is going to determine how much water we lose. So ADH, when it is secreted, the hypothalamus produces ADH and stores it in the posterior pituitary. When it is released, associated with wanting to conserve water, so if we have a high plasma osmolarity and a low blood osmolarity, then we're going to secrete the ADH from the posterior pituitary. That's going to cause vasoconstriction of the blood vessels near the surface of our skin, and it's going to stimulate the kidneys to produce extra aquaporins that will increase the amount of water that is taken back into the body, so we don't lose as much. The body also has to balance its electrolytes. So we have a lot of electrolytes. Electrolytes are ions that are in our either in our interstitial or in the extracellular fluids that help to cause the nerves or muscles to function properly. They help in stimulating endocrine secretions, in maintaining blood pH. And so these electrolytes are, so there's a lot of electrolytes, but the ones that we really care about are sodium, potassium, chloride, bicarbonate, calcium, and phosphate. Those are the most important ones in our body. So sodium is a very common, the most common cation ion of extracellular fluids. Hold on one second. As I was saying, sodium is the most common cation ion, so positively charged ion, in extracellular fluid. And sodium is one of the most important ions in helping to maintain an osmotic pressure, the osmotic pressure gradient between intracellular and extracellular environments. So there are disorders associated with too much or too little sodium. Hyponatremia is low blood sodium levels, and so this is often associated with increased water intake. Different disorders like Addison disease or diabetes mellitus. Treatments typically are you're going to treat the symptoms. So you treat the symptoms and you fix the underlying cause. If the cause is Addison's disease, then you're going to increase the amount of aldosterone and cortisol in our system. If the disorder is due to not eating any sodium, then you might just increase the amount of sodium in the diet. Hypernatremia, this is typically more common in developed countries because we have a lot of sodium in the foods that we eat. So we get lots of sodium just in a typical meal with, you know, a burger and fries. You'd have a lot of sodium. And so this can be caused because we're just eating too much sodium, but it can also be caused if we lose too much blood or water from our blood, or different disorders where we're not controlling sodium. So maybe there's too little aldosterone, or too much aldosterone being produced. So we're increasing the amount of sodium in our system continuously. If we are increasing the amount of, or if we're not producing enough ADH, then we might be getting rid of too much water from our blood, and that again would increase the amount of sodium to water ratio. And so treatments for this would be, again, fixing the underlying cause, but we treat the condition by decreasing sodium in our diet initially. Potassium then is one of the most common intracellular ions, and this is a cation again. So sodium is on the extracellular region, potassium is intracellular. And potassium helps in maintaining a resting membrane potential for muscle fibers and for neurons. Hypopotassemia or hypokalemia is abnormally low levels of potassium, whereas hyperkalemia or hyperpotassemia is abnormally high levels of potassium. And so in hypopotassemia, we would this could lead to hyperpolarization of cells and the inability for cells to actually depolarize, and so our muscles and our neurons would not fire. Hyperkalemia would be the opposite. It could cause a partial depolarization and then lead to the inability of repolarization, which would then cause us to be unable to stimulate those nerves. So treatment for this disorder, we would have to either decrease the amount of potassium or increase the amount of potassium in our system. Typically, if we have sodium in our diet in a developed country, we typically also have chloride in our diet because sodium and chlorine come together in sodium chloride, forming table salt. And so chloride is the most common extracellular anion. And this contributes to the osmotic pressure gradient as well. And it functions in maintaining a neutral extracellular fluid environment. So hypochloremia is lower than normal chloride ions, and hyperchloremia would be higher than normal chloride ions. These are regulated with sodium. So if we're increasing sodium, we're increasing chlorine as well. Treatment would just be to, if you need more chloride in your system, then you would likely have more sodium needs as well, and they would increase the amount of salt in your diet. Hold up. Oh, okay, so now we're going to talk about how do we maintain potassium, sodium, and chlorine. So this is associated with aldosterone. Aldosterone is your salt lover. So aldosterone is going to increase the amount of sodium and chloride that enters the body, and inversely, it decreases the amount of potassium. So anytime sodium comes in, potassium is released through those sodium-potassium pumps. And so if we need less sodium, then we're going to decrease the amount of aldosterone, which will allow us to keep more potassium in our system. So they are kind of inversely regulated. If we need, so think about it this way: if your body needs sodium, that's usually associated with low blood pressure, we're going to increase aldosterone. That increases both sodium and chlorine ions, and we're going to release potassium out. If our body needs more potassium, then we're likely not going to need the sodium or chlorine at the time, and so we're going to lower the amount of aldosterone that is typically, or that would be produced, and that's going to allow us to keep the potassium, and then sodium and chloride will be released in our urine. And so how do they actually work? The renin-angiotensin system here, you have renin produced by the kidneys, you have angiotensinogen produced by the liver. Angiotensinogen moves through our system. It's an inactive protein, but when it comes in contact with renin, typically associated with low blood pressure, it's going to be converted to angiotensin 1, and as it moves through our pulmonary system in the lungs, it's going to be activated and converted to angiotensin 2 by ACE. So angiotensin 2 stimulates an increase in aldosterone and antidiuretic hormone, for that matter. And angiotensin 2 increases blood pressure. Aldosterone increases sodium and chlorine uptake as well as watery absorption. And so altogether, it's going to increase the amount of salt, chloride, and it's going to decrease potassium. If we need less sodium, then we're not going to be releasing the renin. Angiotensinogen will just stay in the system as angiotensinogen, which is inactive, and we're not going to be taking in as much sodium or chloride or water. We're going to be releasing them, and we're going to retain the potassium. The next ions are bicarbonate. Bicarbonate is one of the most abundant anions as well, and what bicarbonate does is it helps in maintaining the acid-base balance of our system. So regulation of bicarbonate is totally associated with how acidic our blood is at any given time. And so this occurs by the kidneys. Calcium is a very common intracellular ion. It's found mainly in our bones and in teeth. But the calcium in our bone and teeth are not typically the ones that are able to interact and be used. And so we're constantly increasing calcium by breaking bone down or by taking in calcium in our diet. So calcium ions are needed for muscle contractions, for nerve impulses, for for blood clotting. Hypocalcemia is lower than normal blood calcium levels. Hypercalcemia is higher than normal blood calcium levels. Typical reasons for hypocalcemia: lack of calcium in the diet, lack of vitamin D. Hypercalcemia, which is not as common, would be possibly associated with hyperparathyroidism, where your parathyroid gland is producing too much parathyroid hormone, which stimulates calcium release from the bones. Phosphate then is seen bound to calcium in bone and teeth. It also helps to make up the plasma membrane. It makes up adenosine triphosphate. it helps in making up nucleotides. So we need phosphate in our diet as well. Hypophosphatemia is lower than normal phosphate levels, whereas hyperphosphatemia is higher than normal phosphate levels. And these are regulated together as well. And so we regulate these by two major hormones, the parathyroid hormone, which we talked about, and a hormone called, parathyroid hormone, as well as the active form of vitamin D. And then we have on the other side calcitonin. So when our blood calcium levels are very low, this is going to stimulate the parathyroid glands to release parathyroid hormone. Parathyroid hormone then stimulates our kidneys to produce calcitriol, the active form of vitamin D. It's going to stimulate our bones to, our osteoclasts of our bones, to break down the bone and release the calcium into our diet, or into our blood, I should say. It's going to stimulate calcium absorption in our kidneys and our small intestines. This increases the amount of calcium we keep in our system. Inversely, if we're increasing calcium, we need to decrease phosphate. And so when we break down the calcium phosphate from our bones, the phosphate is going to be excreted from our body. If we have high calcium levels, we want to lower those calcium levels, then we're going to, that's going to stimulate our thyroid gland to release calcitonin. Calcitonin then inactivates osteoclasts and activates osteoblast activity. Osteoblasts then take in calcium and phosphate from our system and builds up the bony matrix, hydroxyapatite. This is going to lower blood calcium levels down to where they need to be. All right, I'm going to stop here. In our last video, we'll talk about pH. See you guys soon. Bye.